Hey mihi mahana kia koto katoa, gramila mahagav asachtam privilege, large live in you. So I speak in Irish, that was the second sentence, just to settle myself down. I am from Ireland. I hope my accent, that it's easily identifiable. Thank you very much, Bob, for the privilege of speaking at this conference this afternoon. I have only a few slides, and really the purpose of the slides is to give you a rest a tiny bit from listening to me. So a lot of what I have to say I'm going to read, but hopefully in an afternoon you won't drift asleep, but I'll keep an eye on you. So the clock is ticking, and I think it's about 40 minutes. Is that right, Bob? Yeah. So who am I? As a palliative medicine physician, I cared for 400 to 500 people each year who have advanced disease and who have died. And so to begin, I would like to remember and acknowledge all those people over 23 years under my care who have died. I come from a long line of doctors. Since 1905, 3 generations and 7 doctors. And from my physician grandfather, I learned the art of attending in medicine, and from my physician father, I learned the art of observing. I'm a palliative medicine physician for 23 years, trained in Ireland, Scotland, the United States, and now I work in Wellington, Aotearoa, New Zealand. I practice the art and science of medicine. For more than 100 years, my people have cared and served as doctors. And my whole being cries out, no, don't do this. Do not legislate for euthanasia or physician-assisted suicide in this country. What is palliative medicine? The word palliative derives from the Greek or possibly Latin word pallium, meaning a shield or a cloak. The idea is that the hospice or the palliative care team is cloaking or shielding the person in care, not able to remove or cure the underlying illness, but committed to not abandoning the patient physically, emotionally, or spiritually. And the following is part of the WHO International Definition of Palliative Care. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. And these 3 lines are important. Palliative care provides relief from pain and other distressing symptoms. Palliative care affirms life and regards dying as a normal process. But palliative care intends neither to hasten or postpone death. And because of that last sentence, we're immediately in the debate around euthanasia and assisted suicide, because palliative care intends neither to hasten or postpone death. As I said, these slides aren't really necessarily supporting what I'm saying, they're just giving a bit of a visual. So what do the professional medical bodies say? The New Zealand Medical Association defines euthanasia, and probably Jane has already done that this morning. And the NZMA, that's the professional body representing 5,600 doctors in New Zealand. Euthanasia to them, all those doctors, is the act of deliberately ending the life of a patient. So, and for the NZMA, that's unethical. So in the Netherlands and Belgium, euthanasia involves the doctor sitting beside you, putting in an intravenous line, access, and injecting phenobarbital or propofol or a curare agent. The purpose is to anesthetize you and then to paralyze your muscles, and you die within a few minutes. That's the act of euthanasia. Physician-assisted suicide is whereas I, as the doctor, you come to me and I give you a prescription to take phenobarbital, which you go to the chemist, a willing chemist, and you collect that and bring it home, and you drink it as a liquid. So that's physician-assisted suicide. I've assisted you, but I haven't actually injected the medication into you. So for the NZMA in New Zealand, both physician-assisted suicide and euthanasia are unethical. The NZMA, however, encourages the concept of death with dignity and comfort, and strongly supports the right of patients to decline treatment, that is ethical, or to request pain relief, and supports the right of access to appropriate palliative care. So in requesting pain relief, one of the audience, Renee, has mentioned to me that people get a bit confused about the use of morphine. And I'm not really, this lecture isn't about that, going into that detail. But just to say, morphine isn't used in the Netherlands and Belgium for euthanasia, physician-assisted suicide. Morphine doesn't kill you. You know, not in our world, in the world, and it's not used for euthanasia. It's not an effective agent to kill people. People are often dying, and then the palliative care nurse comes along and and the palliative care doctor, and you get an extra, the person is given a dose of morphine, and then they die, and everybody thinks, my God, the morphine has killed them. But for the palliative care nurse and doctor, that patient is dying, but was distressed by pain, and is given an appropriate dose to relieve their symptoms, and it just happens that they died afterwards. So that's my experience of 25 years in palliative medicine. So the NZMA position opposing euthanasia, saying it's unethical for doctors, and even if it's legalised in New Zealand, it would remain unethical. So, and the NZMA have joined with the WMA, which is the World Medical Association, and they have a resolution that says, it reaffirms its strong belief that euthanasia is in conflict with the basic ethical principles of medical practice. And the World Medical Association strongly encourages all national medical associations and physicians to refrain from participating in euthanasia, even if it's legal in a country. So you've got and then, in addition, what's interesting is the World Medical Association is an international organization representing physicians. It was founded in 1947, an interesting year to note when it was founded. Physicians from 27 different countries met at the first General Assembly, and it was created to ensure the independence of physicians and to work for the highest possible standards of ethical behavior and care by physicians. And this was particularly important after the Second World War. So the World Medical Association and the New Zealand Medical Association are aligned. And while chair of the New Zealand Palliative Medicine Doctors Group, we canvassed our members, and we also have a strong statement opposing the legalisation of euthanasia, that it's not consistent with palliative care. So that's just to put it in context. So in my experience, no patient has consistently requested that I, as their doctor, end their life. But patients do say, this is hard, I wish it was all over. That's not uncommon. So our response as a palliative care team is to explore all the aspects of this statement gently and carefully with that person. We see that statement as an invitation to ask more, listen more, to be present, and explore who is this person who's suffering. And after so many years of experience, we know that such an approach works. Every day I spend hours with people who are facing death, who suffer, whom we help. And the greatest need in my experience is to be truly heard, truly listened to, not abandoned emotionally or physically. Recently, a 48-year-old lady who had diagnosed with widespread cancer, and it had taken a year for this diagnosis to be made, so she was greatly distressed, as was her family, not just in the diagnosis of cancer, but in the length in which it took to make the diagnosis. And she said to me, this is all too much. And I said, what's too much? Is it all of this that we're doing to you in the hospital? You don't want any more of this chemotherapy? And her reply was, oh, no, I do. So just that phrase, this is all too much, doesn't mean that the person wants to end their life or have their life ended. So later on, a few days later, the same lady said, I just want to be cared for with kindness. Someone to take me for a cigarette, give me a wheat pack, make me a cup of Milo. So people yearn so much to receive care unconditionally. They are acutely sensitive to any sign that others feel that they are a burden. And in that situation, if they feel that, if they sense that, they close down, retreat, and their overall suffering increases. A few years ago, I had the privilege of speaking on a Catherine Ryan 9 to noon radio program, my big day out. And I explained to the listeners that the Prime Minister's comment, and at that time it was John Key, he had made a comment that euthanasia was happening in New Zealand hospitals already. So I explained on the radio that this was untrue. I said that despite John Key being the Prime Minister, in medical terms, he was a lay person. And like many lay people, he confused the appropriate withdrawal of treatment, such as a ventilator in ICU, as euthanasia, while we as doctors recognise the clear distinction between that and the doctor intentionally ending the life of a patient. So if you've been in a road traffic accident or your relative has and they're brain damaged, or in a skiing accident they're brain damaged, and they're put on a ventilator for several days to see will they recover, but in fact the brain has died and the machine really is just keeping their breathing going, what in fact is the machine is prolonging their dying. The person is actually... So to withdraw that ventilator, I mean, everybody's different, so I'm just kind of generalizing. To stop that ventilator when the brain is all actually dead is not euthanasia. That's appropriate withdrawal of treatment because you were prolonging their dying. Does that kind of make sense? So on return to the hospital after that interview on the radio, I visited a man on the cancer ward in Wellington. He had just that morning been told that his lymphoma had recurred. A kind care assistant was helping him into a reclining chair. He was a very large man and he was crying. During that visit, he referred to the recent media reporting on euthanasia. And he said, "I thought of killing myself several times in the last year, but now I know what hospice offers and what palliative care is about. All I want now is palliative care." So that weekend, he was transferred to the hospice, where he arranged a party and died there 2 weeks later. Another patient on the oncology ward that very day was Jane Malcolm. And as I walked into Jane's room, her father, Jeff, approached me to shake my hand, thanking me for my stated opposition to euthanasia. It is interesting that Jane was 42 years of age, a lawyer, and had a brain tumour. About a year later, another 42-year-old lawyer with a brain tumour, Lucretia Seals, made headlines in her High Court application that her GP would not be prosecuted if the GP ended her life. So that was Lucretia. So two people very similar took two different paths. Jane and her parents took a different approach to Miss Seals and her family. Jane went home from the hospital and was cared for at home by her parents, supported by community palliative care, and died at home. Jane didn't make the headlines in the papers, as Lucretia did. A patient in her 80s was admitted through the emergency department, having taken medications that she had collected over time, following advice she had been given and received from the Voluntary Euthanasia Society in New Zealand. Her suicide note referred to recent recurrent falls, which led to fractures and a likelihood that she might fall again, as a result of which she would be, in her words, condemned to an existence in a rest home. In her words again, she would not consider that to be life, having recently had experience of being in a rest home. She implied that she was driven to that drastic step of suicide because of the rest home experience. She added that euthanasia would have been preferable with her family around her. If she lived in the Netherlands, she would have satisfied the criteria for euthanasia. Following admission to the acute hospital, this lady was cared for meticulously and with great attention to her physical needs, to her son's needs, with careful reduction downwards of harmful medications. We discovered that the pain medication patch, which had been increased in the community, was adding considerably to her anguish, which was being misunderstood as pain. After 2 weeks in the acute hospital, she was smiling, chatting contentedly, surrounded by flowers from her garden, photos of her son and her deceased husband. This lady in her suicide letter implied that the experience of care in a rest home drove her to make the decision. I imagine the decision was much more complex. She was a highly educated lady, proud of her academic achievements, a member of the Voluntary Euthanasia Society. I have many concerns about the legalization of euthanasia in the context of this story. My concern is the precipitant of the decision, her experience of the rest home. My concern is the side effect of strong pain medicine, the dose of which was increased unwittingly and due to inadequate knowledge that added to her distress. My concern is how she blossomed while receiving good care and how she suffered in the absence of good care. My concern is that people such as this lady are vulnerable and are seriously at risk of poor care, and in the presence of euthanasia will be seriously at risk of being killed. I'm just checking the time. In medicine and palliative medicine, much is written about dying with dignity. It's a phrase that the Voluntary Euthanasia Society internationally have adopted. But exactly what do we mean? Harvey Chochinov, a Canadian, has studied this concept in relation to people who are dying, and he says, one of the most confounding challenges faced by end-of-life care providers is helping patients achieve or maintain a sense of dignity. Our prior studies of dignity in end-of-life care have shown a strong association between an undermining of dignity and depression, anxiety, desire for death, hopelessness, feeling of being a burden, and overall poor quality of life. Patients deem a sense of spiritual peace, relieving the burden, and strengthening relationships with loved ones among the most important facets of end-of-life care. So how do I recognize dignity when I see it? Is it what others, and I'm thinking of a patient, I'm going to tell you a patient's story. How do you recognize dignity? Is it a decision one makes to be dignified? Is it what others do to you? Is it how you respond to others? How do you die without dignity? Is vomiting as you die an undignified death? These are just questions. Is being alone when you die an undignified death? It is said that rather than viewing death with dignity as a separate construct, it might be viewed as an interactive process between the dying and their caretakers. Terms such as pride, self-respect, quality of life, well-being, hope and self-esteem all overlap with the term dignity. While most of these terms refer to an internal state of mind, dignity is distinctive in that it also has an external component based on the perception of one's worthiness of honour and esteem from others. So this is important in the debate around euthanasia because those in favour of euthanasia present euthanasia or the intentional killing as a form of maintaining dignity. It's much more complex than that. So this is a story. Gold is the colour that comes to mind. Her little face without teeth was wrapped in a scarf of deep blue and gold. As we entered the hospital room, we saw the hands that tucked the scarf around her face. She smiled with her eyes and her whole face, her two daughters by her side, watchful, totally engaged. The photograph of a handsome soldier leaning against an Italian stone building in sunshine many years ago rested on the shelf to her right. The photographed face of her great-grandchild, a baby, on the hospital wall opposite her bed. There were 3 vases of lilies, maroon, orange, and white. This space embodied dignity. I just wanted to linger there, to be part of this inspiring space. How was it created? 2 days earlier, the night doctors handed over to me that this 91-year-old woman was dying. She had collapsed at home the previous night and was unconscious. At this age and this presentation clinically, it was deemed highly likely that she'd had a brainstem stroke, which is not a good prognosis. In view of the poor prognosis, nurses had thoughtfully placed the patient in a side room rather than a ward space. That's usually for people who are dying. The lighting was low. There were 3 generations of family in the room. The daughter and nurse stood closest, leaning in attentively. The air was of concern in anticipation of her dying. When I saw Mrs. Jones, felt her hand, asked for more detail from the family, I wondered whether her situation was in fact irreversible. So in the dim light, trying not to counter all that had been said by ED doctors, all that had alerted 3 generations to arrive in the early hours, I introduced the new idea that we will wait and see, and that maybe she will wake up. By the evening, she was rousable. By the next day, she could say a few words, smile though a bit confused. We treated her kidney infection. She gradually sipped water and smiled more. There we had the resurrection of a lady, attended with infinite patience of a caring family. They loved their mother. They loved their grandmother. I hoped that the young doctors with me understood the mystery and power of what was going on in that room as we visited on our rounds each day. Not the fact that she got physically better, but the honour and dignity that was in the air. We entered the space of dignity and breathed the same air. It did not belong to one person, it was co-created. So I'm giving you a sense of what it's like to live in my world. And where the passion is in my soul and in my body opposing euthanasia. Because this is about care, they're examples of care. And it's not solely the doctors and the nurses, it's a community. We all need to care, we need to learn how to care. So, just to alert you in relation to medicine, there's a great ethicist, Margot Somerville, in her book in 2015 entitled Ethical Cleansing of the Medical Profession. She said that treating physicians as mere technicians fails completely to take that omnipresent ethical practice of medicine into account. So the practice of medicine always and unavoidably involves ethical and moral issues. The push to abolish respect for physicians and other healthcare professionals' freedom of conscience also reflects an emerging view that physicians are mere technicians able to provide services that patients want and have a right to access. So this year, 15 ethicists produced a guideline document in which they challenged the right of healthcare professionals to conscientious objection. One of the signatories is a New Zealand bioethicist. So not only is the euthanasia coming to the fore, but also the same kind of people with the same view of the world also want to get rid of the idea of conscientious objection among healthcare professionals. Their argument is that if something is legal in the country, the patient has a right to it, and if someone has conscientious objection, they need to pay back the institution to which they work for the inconvenience they're causing by having conscientious objection. So it's just to alert you, these are realities. And the thing is that more and more, the setting of patient, this patient choice movement, the choice in end-of-life care, if patients are given unrestricted right to consumer choice, and if doctors are the agents of euthanasia, then doctors will become the suppliers of goods and services in the free market. Such a position could emerge out of politically led consumerism, but if it does, the price will be the end of medicine as a profession. And I mean, that doesn't. I think that's true. So, a great Canadian palliative medicine physician, Balfour Mount, reminds us of the role of the doctor as a healer, and it's challenging to practice this healing role today. And as a consequence, we may choose to forget this vocation, which is to cure sometimes, to heal often, and to care always. And in forgetting, we are at risk of losing the heart and art of medicine. And such a loss would have tragic consequences for my profession. So quoting again Margot Somerville, an absolute barrier to physicians becoming involved with acts that intentionally inflict death is that doing so would be incompatible with their healer role. One understanding of medicine's healing mandate is the notion that healing amounts to caring for the whole person. And that has a deep historical roots in Greek and French and Anglo-Norman word physician derives from the word denoting a practitioner of the art of healing. And healing is inseparable from the need of humans to cope with the bafflement, fear, and suffering brought on by sickness. So healing is a journey rather than a destination, a process rather than an epiphany. Suffering is fundamentally a sense of one's own disintegration, of loss of control. By counteracting those perceptions, a person can be helped on a healing trajectory. even as death approaches, and that's what I've experienced throughout my career. Healing interventions are always possible. One can die healed. So I'm just going to refer to Rob Jonquière, who's a Dutch general practitioner who visited the Netherlands, or visited New Zealand about 2 years ago. He spoke in Wellington. He spoke throughout the country. He's the communications director for the World Federation of Right to Die Societies. So in the Netherlands, he was one of the first doctors to campaign for the legalization of euthanasia in the Netherlands. And he describes his view of the elderly. So in the Netherlands, it has been suggested that euthanasia not have as many restrictions as it used to have, that there shouldn't be an age limit or that there shouldn't be any limit. So for example, it's been suggested that people over 75 who are tired of life should have access to euthanasia, and you simply have to be tired of life. So Rob Jonquière's description of the elderly, this is his view. The elderly have feelings of detachment. They have feelings of isolation and loss of meaning. They're tired of life. Their days are experienced as useless repetitions. The elderly have become largely dependent on the help of others. They have no control over their personal situation and the direction of their lives. Loss of personal dignity appears in many instances to be the deciding factor for the conclusion that their lives are complete. The conclusion that life is complete is reserved exclusively for the concerned persons themselves. And he says they alone can reach this decision, whether or not the quality and value of their lives are diminished to such an extent that they prefer death over life. So he says it's never for the state, society, or any social system to question or otherwise interfere in such a person's decision. And so that's his argument in favour of those over 75 just being tired of life, being allowed to access euthanasia. So in other words, really, if you put safeguards when you introduce euthanasia into a country, they will not hold because they will be challenged and they will fall down, and it's logical that they will. If you decide that euthanasia is to be legalized in a country and it's on the basis of people are suffering and they have a right to this as a form of treatment. Euthanasia is a way of treating suffering. If that's what society decides, then you can't say it's only for those over 18. What right have you to deny someone under 18 suffering? Do you understand? So even if they say, David Seymour says or Marion Street says it's only for over 18s, that can't hold. It will be challenged and will fall later. So Dr. Jonquière spoke in Wellington in February 2015, and I was there shaking in the back. I find it hard to go to Voluntary Euthanasia Society meetings, particularly in a church. But anyway, and I wasn't brave enough to ask any questions, but I wrote down my reaction. So I've entitled this tiny piece, Why Be Careful? So why be careful, joked Dr. Jonquière, and there was laughter from the audience. So Dr. Jonquière was responding to a question from the floor. It was about towards the end of his hour-long lecture. So he was responding to a question from the floor at his lecture. The question was, what dose of medication does he use to euthanize his patients? And he replied, I use phenobarbital to sedate and a muscle relaxant. And he said, and in relation to the dose, why be careful? The audience laughed. Seated in the audience at the back of the church hall, I felt weak. As a doctor, I care for people who are facing death, and every day I try to be careful. I teach medical students why we need to be careful and how to be careful. Caring for and serving someone who is vulnerable, sick, or dying requires great care. I was deeply troubled by the flippancy and the laughter among this largely pro-euthanasia group. Do they really know what this is about? By their proposed legislation, they seek to change the nature of our medical profession from care always to why be careful. All my training, discipline, and professionalism as a palliative medicine doctor is about being careful, being exquisitely careful with the lives of others. Now, you could say logically he's right. You can't overdose the person if you're trying to kill them. But we're not talking about logic. This is about people. So Philippa Malpass is a teacher of bioethics to medical students in Auckland University, and she did a study. She's a member of the Voluntary Euthanasia Society, and she did a qualitative research, and it was published a few years ago, talking to 11 people who were over 80 who were members of the Voluntary Euthanasia Society, and why they were in favour of euthanasia. And she found that the main request for euthanasia was that they felt a burden and loneliness. And my response is euthanasia is not the answer to society's disease of loneliness. International literature has shown that the strongest predictive factor for a wish to hasten death in those with terminal illness is hopelessness. Again, euthanasia is not the answer to society's disease or an individual's disease of hopelessness. The word euthanasia disguises a practice which one might abhor if it were given another name, killing. And let us take the protective cloak of medicine away and see what this is, deliberately ending the life of another person. Being treated with dignity is not only about self-control, independence, maintaining physical function. It is also present when one is honoured and treated with esteem. Caring lovingly for someone is itself an act of dignity. So the study participant in Philippa Malpass's paper, their fear was of institutionalised ageing. They were afraid of ending in a rest home and being a burden and being left there. An ageing person, it is assumed, will not be loved and will not receive care. I groan to read the study participants' comment, and their comments, when I'm useless and have nothing to contribute, that's when I want euthanasia. Does fear of growing old justify euthanasia? Does fear of being a burden justify euthanasia? If so, what a cruel society we've created. The inconvenient truth is that being a burden can happen at any age, infancy, childhood, teenagers. This is the very reason not to legislate in favour of euthanasia. In the court of usefulness, who presides? How do we ensure that older people feel useful? What right have we to make older people feel useless? Again, quotes from interviewees in this study are challenging. A quote, "Old people are a drain on resources." Is this a reason to legislate for euthanasia? There's no limit to the drains on resources. Alcoholics, drug addicts, depressed people. They see older people, inverted commas, getting little sympathy from caregivers frequently. Is this the impression we're giving to older people? And this is the challenging area, because the answer is yes. There's a truth in this. And this is a challenging area. The problem does not reside with the older people who request euthanasia. The real problem is that people in our midst feel they are a burden and feel or know we will not care enough. And I think they're right. The easy answer for us is to bury the problem. The more uncomfortable reality is to look at ourselves, the carers, the able-bodied, and say, you know, they're right, we don't care enough. We must show our older people and our young people that we know how to care for each other. And what about the people who already feel they're a burden? As the people from the disability sector said, we shouldn't be paying for our lives because health and social services can't step up to the plate. And this is the disability sector, people I'm quoting from. There's this continual apology for your own existence. And when you start internalising that, what happens? When you go to a doctor who is supposed to be helping, you negotiate life with a disability, and they're saying, well, death is always an option. So there's the burden some people, example, Philippa Malpass's study participants, there's the burden some people feel at the thought of being disabled, and there's the burden disabled people already feel in struggling to live in the society we have created. The latter will be compounded by legislating in favour of euthanasia. People are asking not to be considered a burden. That's what I feel when I sit with people. And they don't necessarily ask it with words, but their spirit is asking it. They're asking, are we a burden? And we say yes when we legislate for euthanasia. So I responded to Philippa Malpass's research paper at that time, and her response, which was published again, and she gave further detail. A person this is her quote, may wish to end their life at a time of their choosing, rather than using their financial resources to sustain a life which they no longer value, preferring rather to leave that money to benefit others, for example, their families. And she agrees with that. So, although Marion Street and David Seymour are not saying we want this so that people can save money for their family, in fact, the members of the Voluntary Euthanasia Society have layers and layers of the reasons that they want this legislated, and it's not the one that's up front in the media. Just to say, this is not a helpful slide to you. I like it because of the colours. It cheers me up. But it's my summary of really where the debate should be at. I've got I at the top there, and it's the individual, it's the I, it's the Lucretia Seals, it's the dreadful Brittany Maynard in the Oregon last year. It's the stories we hear of the individuals who are suffering, and we're moved. I mean, we were moved, all moved. It was dreadful that Lucretia Seals died. It was dreadful that she had a brain tumour. She's a beautiful lady, was hoping to have a child, was a very great lawyer, and her poor husband left. We're moved by their stories. But I feel what we really should be talking about is the layers down below. So if I turn my head, I can't see that either. You won't be able to hear me. But so this is, I think, where all the conversation's happening at the top of the pyramid, whereas I think it's way down here is where it's really at. We hear the views of individuals on the media. They'll talk to the Care Alliance and they'll talk to the Voluntary Euthanasia. They'll talk to Bob and he'll be on the television. And then they do surveys and say 70% of people are in favour of euthanasia, but the question they asked is not that searching, so it's not really accurate. Then you'll have the media doing profiles, and then we'll have a political debate like last week with Marion Street and Laura Finlay. Then we have statistics about how many people are committing suicide. And so we've all of that. Then we have the medical organisation voices, what we think. Then we have the palliative care world who are opposed to this idea of euthanasia. Now, not all doctors in palliative care are opposed to euthanasia, but 90% are. And individual doctors have different opinions. But what I'm speaking about is what should be the professional stance. As a profession, what stance should we take, irrespective even of your individual view? And as a professional, as a body, professional group of I think medicine should stay out of euthanasia. If society wants it, they can train other people to do it. It's not difficult to kill someone, and you can't do an overdose. So all you need to do is put in an IV line. So leave doctors out. There's no need for them to be part of it, and it will ruin, in my view, the profession of medicine and the trust and everything. But what I really would like us to be talking about is our understanding of suffering, our understanding of caring, our response to vulnerability, our response to uncertainty. How do we deal with it in the society we live? And basically our fear. I'm afraid of dying. Now, maybe you all have great religious faith, and I have some, but I mean, the real truth, if I'm in the corner, is I'd be terrified of dying. I'll go kicking and screaming. So the thing is, I actually think that's underlying all of this, our fear of the existential dread. And even if you have a deep faith, I still think that it's a big part, that existential issue, underlying, and it just leaks out or in this way. Anyway, that's the purpose of the slide. So, the goal of medicine is not to give up caring. In my view, you can harm by a look, by a phrase, going on a ward round, not having the time, not just turning abruptly, not attending to the family who's sitting beside, not attending to the nurse who's trying to care, just being too busy. You can actually cause harm. I can do it every day. I do it unintentionally, but I try not to. You can harm by a look, by a phrase, because of the vulnerability of a person who's ill. Such people are extraordinarily vulnerable, calling forth in us extraordinary compassion and care. And we need skills and knowledge to know how to provide that exquisite, competent care. That's what we should be talking about. Margot Somerville, the bioethicist from Canada, she gave a talk, and one of the incidents she described, that she was giving a talk to a large group of people in Canada, and it was her reasoning for her opposition to euthanasia. And she said, just as I've said, that you don't need a doctor to do it or a nurse. And in fact, if you want it to be legally watertight to make sure that all the parameters are covered and all the paperwork is done, You should entrust it to lawyers. And someone put their hand up and said, oh no, that would be killing. So her point is, when you take the cloak of medicine off it, away from this, that's in fact what it is. So this is, someone else wrote this lovely little piece, which was in the Nathaniel Report a few years ago. It's to give you a sense of what's the core, the essence of care. A man who had Alzheimer's disease and was dying had struggled for so long. He had endured memory loss for many years. All the while his daughter had taken very good care of him. One day towards the end of his life, she asked him, "Do you know who I am?" And he replied, "No, I don't know who you are, but I love you." So euthanasia legislation, in my view, and this is all about me, euthanasia legislation will hurt the profession of medicine irrevocably. Euthanasia will expose further the vulnerable in New Zealand society. Euthanasia will not solve the aching loneliness of our broken society. Euthanasia will be a national disaster. Thank you.
Sinead, you mentioned that of palliative care doctors, 10%, well, you said around 90% opposed it, but there were some palliative care doctors that do support euthanasia. Have you ever asked them why? You know, what's their justification for that?
I haven't asked them why. Again, it's in Australia that I'm most aware. So there's been the Palliative Medicine Doctors Group in New Zealand and Australia is one organisation. So the New Zealand branch is a branch, but it's quite strong. So there's been some retired professors of palliative medicine in Australia who've gone onto the side of Andrew Denton, who's a broadcaster and doing a lot of work in Australia to legalise euthanasia, particularly I think in Victoria at the moment. So I don't know why he has aligned. I mean, I don't know. And then there's
because his father died recently, and he saw
Ian Maddox.
His father died.
Oh, Andrew Denton's father.
Yes.
Yeah. I understand why Andrew Denton. I don't know why the palliative medicine. I mean, for some people, I suppose part of the work of palliative care as a doctor, and I'm sure as a nurse as well, or as any worker, is to stand. You're standing with suffering. You're standing with what's going to happen. You know, it's a human reality of dying. It's going to affect you too. It's and if you're open to really be present to someone, you have to actually learn about yourself. So there's an awful lot of self-awareness and exploring of yourself as part of the world of palliative medicine, what you need to do to keep an eye on yourself in that space. And we're all different, and we all approach palliative care. Some people approach their job as a doctor in palliative care as symptom control and just using medication, and they won't go into that space of being fully present and exploring the spiritual. Am I making kind of sense? There's varying ways of being a doctor in palliative medicine. I'm in the view of that you give all of yourself and you're present in your whole being. So I'm just suggesting that maybe some doctors aren't able to be present to the suffering or whatever it is, the reality of someone dying in front of them. And they join with the patient or the family in saying, yeah, there's only one way out of this is too much. So I think it's when a doctor feels that euthanasia is the only way, it's coming from their own personal experience of life and their own way of coping with that. That's kind of an answer, but it's another good question from Bob.
Sinead, Maggie Barry says that elder abuse is a huge problem. Would legal euthanasia reduce elder abuse or increase it?
Well, the audience have already said, I think. I mean, I just think people are vulnerable. And I mean, I'm a general medicine physician as well as a palliative medicine physician, so and there's a big pressure in the hospital about people not staying too long, like the length of stay. There's an average 1.6 days, length of stay in acute hospital, this kind of thing. So there's under pressure. And even though I'm a palliative medicine physician and I've described how much I care and passionate about, when I'm looking after patients, and I can remember a lady, it was a few weeks ago, and she didn't want to go to a rest home, so we got the occupational therapist, the physiotherapist, and then I came along, and by the end of a day, we had convinced the lady that the rest home was a good idea. Now, we care, but actually, it's, her husband didn't want her to go home, and so we really coerced her and to go to a rest home. Somewhat, there's and that's just about going to a rest home, because it's complicated nowadays. There's nobody to, your husband can't look at, you can't stay at home. There isn't the support. So I feel that's an example of someone as a doctor who actually tries to care and be holistic in the care. But even I'm not, does that kind of make sense? So when euthanasia is legalised, and it's hard to care for people, and it's hard to care for people who are struggling, who are dying, who are distressed. It's an intensive form of care. It requires great skill and experience and a team, and it's tiring, So it will be easier to suggest euthanasia, and if society, legalises it, then the law kind of normalises it. It normalises it. It's an acceptable. So I do think the older people who I perceive as vulnerable, as I see people in hospital, they are at great risk. And they will internalise, that's the phrase, internalise that it's normalised. I am getting old, I can't manage at home. I should ask for euthanasia. It's what the lady next door did, it's what my neighbour did. So it's just normal human behaviour will continue. So I think definitely that people are at risk.
Can I run a scenario past you? And it's a real life one. My parents knew a family where the mother had Huntington's disease, and it had passed to the two sons. And so over a period of time, we saw the mother slowly deteriorate with the Huntington's disease. It's not a nice thing to watch, the involuntary movement. It's if you're thinking of fear of dying, it's one of the nastiest diseases around. Now, the two sons were aware that they had the gene and that they were going to get it. And so one of the sons, as soon as he was diagnosed with it, committed suicide. The mother continued, the husband stood by, an incredible act of sacrifice and love, stood by her, cared for her right through to natural death. But it wasn't pretty.
No.
So, and some proponents, especially in Wellington, use that particular family to argue that how can you not allow a person facing that type of ending to decide on the timing of the ending. So I've seen both. I've seen one lovingly cared for beautifully by the husband, as tough as it was, and I've seen the other take not the easy option, but just what other option. So how do you respond to that? How do you respond to people who say, look, if you have that type of ending coming up and you know it's coming and you've seen your mother with it, why shouldn't you have the right to that self-determination? That's the hard cases. Yeah.
So all I can say that I have seen people with Huntington's and with other illnesses that are hugely deforming. I was in Ireland and I visited a hospice 2 weeks ago, and it's a young man from the Congo who was albino, so he should have been dark-skinned and he had no melanin, so he developed a tumour in the side of his face. That's a 22-year-old just eroding the side of his face. And he has to sit there knowing, this is... So, it's not just Huntington's, there's an awful lot of illnesses that are tragic and extraordinarily distressing and extraordinary suffering. But in that ward round, when I went around, I was just an observer. The consultant, the doctor and the nurse were there. The care with which the nurse attended to this young man. The doctor, it was in Ireland, she did the ward round in French. She spoke to him in French because French was his first language. They'd got I know rugby isn't as good in Ireland as New Zealand, but they got the Connacht rugby team to come in and visit him, and they kind of adopted him because of a 22-year-old, and over the last few weeks but I'm just saying his illness is grotesque, the deformity, and he's a 22-year-old. But there is a way of caring for people, and we all suffer in various ways, and what our greatest desire is to be cared for in your suffering, however grotesque it is or it isn't. So I believe, I've no doubt about the anguish and suffering that exists and will continue to exist, but neither have I any doubt about the extraordinary nature of what care can achieve if we look after each other. So, and if someone was extremely anguished in their dying, pain is not so difficult to control now. We're getting better and better at it, but people can have existential anguish and very distressed. It is ethical and appropriate that they're likely asleep or asleep and to give them medication. So they're dying, but it's reasonable that they're sedated. That's symptom control. It's not shortening their life. The intention is to relieve their anguish if we can't access it in any other way. So I suppose I truly believe that palliative care has the tools, if it's supported and got the team and the staff and the expertise to care for people in great suffering. I have witnessed it. The Huntington's is a separate issue that's genetic, so that's another extraordinary burden, and I don't feel an expert in that area.
Okay.